Great. Well, thank you so much for inviting me to be there. I wish I was physically there because I'm in Michigan where it's 90 degrees and most of the area has no power because we had massive thunderstorms yesterday. So I may look a little rough around the edges, but I am really excited to be talking to you today and look forward to our conversation. My goal today is to kind of not go through all the details of everything you ever needed to know about intermittent auscultation, but to put it in the context of how to think about it from a quality improvement perspective, in particular as a strategy to improve NTSV cesarean birth rates. And so in order to do that, what my goal is to talk about sort of my relationship to this work and how I've come to it, highlight some of the evidence base for IA to just kind of level set where we are, talk about implementation of a QI approach to scaling up intermittent auscultation, looking at sort of the resources and metrics that are used as we've implemented an intermittent auscultation bundle in a couple of different scenarios now. And so from that work, I'll share some lessons learned, barriers to success, and some general thoughts about where you might go. As I understand, this is one of the opportunities you have available to you to think about strategies to address your NTSV cesarean birth rates in the state. I'm happy to take questions, and I don't know what your usual format is, but usually if people put things in the chat function, then we can discuss them at the end, unless there's something that I come up with that's confusing or I'm using an acronym. Please call out and make sure that I don't leave you with something that's a misunderstanding or misinformation, that we can clarify anything as we're going. Perfect. So just a little quick background in terms of what brings me to this work. You know, I've been a midwife for a very long time, as you can tell from this gray hair. I was 12 when I started. I like to talk about my 35-year plus career as a midwife, and consistently went from those early years of birth center work where intermittent auscultation was the only methodology for fetal assessment, and that you had to completely change environments if you needed to do something more intensive for fetal assessment, to the standard of care being continuous electronic fetal monitoring. And so it really was always this question of how do you take the evidence that's telling us that intermittent auscultation is a good strategy and reconcile it with the opposite of what's happening in obstetric care, which was to see continuous electronic fetal monitoring being the standard. The other thing that I have always watched in this field is what I often refer to as sort of fixing the wrong problem. As we saw the introduction and growing expansion of the quality of continuous electronic fetal monitoring instruments or the technology behind it, we saw integration of other components of care. So not only can it do your fetal assessment reading, but it's your blood pressure system, it's your charting modality. It's becoming a one-stop shop kind of thing, and it becomes the center of the room. We get very focused in on the technology that's available to us, and we have a lull into it in our culture in general, that technology is the answer. It's an efficiency, it's an economy, and usually we believe that it'll make things better. And that was kind of all of the belief that went into continuous electronic fetal monitoring. So much so that when we have challenges with it, instead of stepping back and saying, why are we doing this all the time? We've added more technology to it with computer-aided interpretation to try to standardize the outcomes. And we still haven't gotten to the other side of really demonstrating that as a universal strategy for use in maternity care, that continuous electronic fetal monitoring offers us any direct benefit. So it's always been something that I've spun around and been frustrated by, and at the same time, also appreciate the value of when I do need it. So I've been part of some externally or grant-funded strategies to look at and the research around the use of continuous electronic fetal monitoring compared to IA, in addition to participating in 2 different collaboratives, one at the state level and one at the national level with ACNM, that implemented intermittent auscultation bundles. And so it's from that background that I'm going to be talking to you a lot today, but also recognizing I'm bringing this sort of overview of changes over time and across my career. So when we think about intermittent auscultation, consistently, every presentation I've ever been to starts with a review of all the different studies that have been done comparing intermittent auscultation to continuous electronic fetal monitoring. And whenever we do that, there's always this dance that we go through of do you do that by describing every single study? Are the studies too far? Have they been done too long ago? Do we still rely on them? And so what I'm going to do is not go through all the detail and put most of the time in that conversation. I'm just going to try to level set with where we are with the evidence and highlight that we do have a solid basis for moving forward with it as a strategy. This is just a quick overview of systematic reviews that have been done of the different studies over and over and over again. What we see is that there is no difference between the use of intermittent auscultation and continuous electronic fetal monitoring in terms of the outcomes that are listed here. And when we look at intermittent auscultation in particular, we see it associated with a decreased risk for cesarean births, decreased incidence of instrumental births, and an increased rate of spontaneous vaginal births. The only thing that has ever come out of the different studies related to a favorable outcome with continuous electronic fetal monitoring was that in an early study, it was found that there were fewer cases of neonatal seizures demonstrated in the use of continuous compared to intermittent auscultation. That said, the clinical outcome was not significant. So it's one of those things where it was definitely a finding. It's something that people will point to immediately, especially if there's anxiety in terms of switching to anything other than continuous. But the overall significance of it is really muted in total of looking at the science. So it doesn't mean that it doesn't make people anxious. And we bring our own clinical experience and our life experience in terms of what we know to how we view the science. And we have different valences. If we only know continuous electronic fetal monitoring and we're advocate of the value and goal of technology, then we're going to have a hard time understanding that something as low tech can be of equal and important value. So it's not uncommon to have a huge challenge in interpreting the evidence. And so we might want to talk about how you can get past that at some point. But one of the things that I think is really important to keep in mind is that the goal of electronic fetal monitoring is to detect intrapartum signs of fetal acidemia and intervene via resuscitation or expedited delivery prior to the development of complications, such as hypoxic ischemic injury or cerebral palsy. In short, the vision for electronic fetal monitoring was really to reduce the incidence of CP. And, just as this always seems to happen to me whenever I'm preparing for a presentation, yesterday, this paper just came out, and it says the same thing that you see over and over and over again, which is that the basis for electronic fetal monitoring hasn't been really supported. And the way to kind of think of that, and I think the authors of this paper really summarized it quite nicely, is that despite widespread use of continuous electronic fetal monitoring in developed countries, and they wrote this about a 2003 study that was looking at the past 30 years in 2003, and now we're still 40 years out and we're seeing the same thing, is that we've had a 5-fold increase in cesarean delivery, but the rate of cerebral palsy in term infants have not decreased. And it's this increase in cesarean rate and its associated morbidity for laboring patients that's the primary concern when discussing universal use of EFM for all patients. And we don't even really discuss universal use. We actually assume it as the standard of care, and we make intermittent auscultation the exception. And the challenge there is that 23% of all the primary cesarean births that occur in the United States are because of non-reassuring fetal heart rate tracings that aren't necessarily indicative of negative clinical outcomes. And so despite the rising rate of cesarean, we're not seeing improved outcomes despite the application of continuous EFM. And to just try to put that in a final summary point, randomized controlled trials consistently of electronic fetal monitoring compared with intermittent auscultation reveal that electronic fetal monitoring statistically significantly increases, as I said earlier, instrumental in cesarean deliveries, but provides no longer-term benefits for the offspring. So we consistently end up in this challenging space. And our professional organizations document this, that we have a strong continual statement in all of our professional organizations, A1, ACOG, ACNM, that notes that there isn't benefit to continuous electronic fetal monitoring and that intermittent auscultation is appropriate as a standard of care for what's defined as low risk pregnancy care. And this has taken on such an interesting turn in that the campaign about choosing wisely, which looks at overuse of interventions in medical care that should be changed because the evidence supports the change in practice, they came out arguing about the need to look at how you monitor how you perform fetal assessment. And these are directed at consumers. These are through consumer report statements. And they found this to be a particularly challenging space to be in as well. And so we have all of this consumer, professional organization, as well as scientific literature advocating for a change in practice. And yet we really do stumble over trying to move forward in that space. And so where I would bring the evidence summary to is why should we focus on the use of intermittent auscultation? And in short, we have the evidence base that supports its use. We have systematic reviews that also demonstrate that compared to other types of fetal monitoring, intermittent auscultation reduces the risk for emergency cesarean deliveries without increasing adverse outcomes. In addition, and this is something that I think we sometimes miss sight of when we look at just the studies comparing modalities, is what can happen with the person depending upon the mode of monitoring. If I'm using intermittent auscultation, there's been an association with increased increased movement, the ability to promote shorter labors then, fewer second stage abnormal fetal heart rate patterns, and decreased cesarean birth rates overall. So the ability to have mobility is really something that's a huge benefit that we often lose sight of in the process of thinking about the two modalities. The other component of it is that we tend to see increased comfort with the ability to have freedom of movement. And in a lot of work we did looking at focus groups of patient care experiences of types of monitoring, that really was consistently cited was that this discomfort with having to stay in one position and not being able to have freedom of movement, that was a significant barrier to the use of continuous electronic fetal monitoring, and IA really did offer some of that. Now there's a sidebar there in that now that we have telemetry, many people point to that as offering opportunities for freedom of movement. The challenge with telemetry is that we're not moving past the limitations of interpretation of the continuous fetal assessments or the monitor strip. We still have that as a limitation. So while we do gain some freedom of movement, we still have association with the interpretation challenge, which is what's linked to some of the challenges with higher C-section rates. So while it may give us a little bit of a support for some of the things that you gain with intermittent auscultation, it doesn't address the underlying problem, which is over interpretation of the fetal monitoring strip. So when you take all those things together, though, my argument for how we should think about the role of intermittent auscultation is that we put a lot of emphasis on category 2 and interpretation of tracings and very little effort on intermittent auscultation. It's sort of treated as a sidebar. And yet, with all of this data behind it and the opportunity to make an impact on our NTSV C-section rates, it seems to me that intermittent auscultation should be a part of any comprehensive packet of strategies that are being used to address abnormal fetal heart rate tracings. And when you're looking at causes of unnecessary cesarean in the NTSV population, in particular, this is a critical component. The two key areas that we see driving the NTSV C-section rate are dystocia and abnormal fetal heart rate tracings. And if we tend to just address one component, dystocia, we tend to see a rise in the number of fetal heart rate tracing indications that are being cited. And if you put your emphasis just on category 2, we see the opposite. So this is a space where being comprehensive in our thinking, it's a really good opportunity to address a more well-rounded way of thinking about how you go about talking about reducing NTSV cesarean births safely. IA is also the gateway to some of the other components that support progress in labor, as I noted. And so it decreases, with that increased mobility, it's a nice companion to a lot of the other practices that you might be employing to support labor progress as well. So with that as background, what I want to do is turn to what we've been able to do in the obstetrics initiative related to the use of intermittent auscultation and talk about the application of that. And to just orient you really quickly, the obstetrics initiative is a 75 hospital quality collaborative that's funded by Blue Cross Blue Shield. And our initial project has been to focus on supporting physiologic vaginal birth and safely lowering the cesarean delivery rate among low-risk patients. So it's statewide. We support data collection, and our overall mission is to create optimal maternity care experiences for all Michigan families. But as I noted, we really are aiming at the NTSV cesarean birth rate as our first area of focus. And then we hope in these next couple of years, we'll be able to expand additionally into other spaces. But when we were looking at how to drive our NTSV cesarean birth rate down and looking at the different contributors, not surprisingly, as I said earlier, you see dystocia and you see abnormal or indeterminate fetal heart rate tracings as your key reasons for NTSV cesarean indication. And in looking at that for us, one of the things we noticed is that as we started to put emphasis on the use of standardized criteria for identifying dystocia, we had a switch. And all of a sudden, abnormal or indeterminate fetal heart rate tracings became the leading indication. And this was our data as we saw it in 2020 and into 2021, and it only continued to increase. So that by 2022, we were seeing a higher rate of the indeterminate fetal heart rate tracing indications. Now, you always want to think positively about why that might be. But one of the concerns we had is that it really was just a shift in what people were using as their diagnosis. So that as we were really looking at compliance under dystocia, people started to potentially indicate more indeterminate fetal heart rate tracings as the indication if the criteria weren't met for dystocia. And so we felt this was where we needed that 360 or more comprehensive approach to the whole thing. And not just looking at category 2, but we really needed to look at offering alternatives to what might be causing the higher rates of indeterminate fetal heart rate tracing indications. And so what we did was we adapted an intermittent auscultation bundle that had been used by the American College of Nurse Midwives for their Reducing Primary Cesarean project. And we really just updated it, and we worked in collaboration with the Perinatal Quality Improvement Organization to also share resources and tools so that we co-branded the materials to move forward. But we used a bundle approach to try to align it with some of the AIM work that's done using that same strategy and approach. And it includes the usual components. So when you look at the bundle, this is the layout, and it includes the readiness, risk appropriateness assessment, which aligns with the R's are a little bit different, but we're still using them to try to lay out things in a similar, familiar way. We have reliable delivery of appropriate care, recognition and response, and then the reporting systems that are necessary. So when we spell it out for the intermittent auscultation bundle, what we had was the readiness, every unit being ready to promote shared decision-making, having consumer education and information, as well as policies available. We had every person who presents in labor participating in shared decision-making regarding the fetal assessment strategy that would be used. We had the opportunity for every person eligible for IA to participate in the decision-making about what would work for them. And then as we had to make changes, we highlighted the need for why changes would be made, again, occurring in a shared decision-making process. And then we evaluated the experience of patient care as they had fetal assessment decisions made. And so what this slide highlights is not only the component, but that shared decision-making was a critical element of all aspects of our use of intermittent auscultation, that we couldn't separate out the need for shared decision-making from any of the component pieces that were part of the bundle. And so when we break that down even further, some of the key concepts were that instead of electronic fetal monitoring being the standard of care, we reversed that and we transitioned to IA to being the standard of care for all eligible birthing people. And that shared decision-making with the birthing person and their families regarding fetal assessment options was essential, and that you needed to also combine this with evidence-based policies for review of Category 2 tracings, so that if you did have an escalation in abnormal fetal heart rate tracings, you had evidence-based strategies for how you would address those. And as I noted, the emphasis on shared decision-making allowed us to really also try to make the birthing person, not the monitor, the most important thing in the room. We acknowledge that there are options and that education would be important to provide, but that in addition, we also cited the opportunity for freedom of movement, the reduced discomfort, and that it wasn't the same as telemetry, but that it was that it did offer some different options, and that if we did have to move from intermittent auscultation to telemetry, that to continuous, that we wanted to also offer telemetry as an option if possible. The other part of thinking about the bundle was the metrics and measures that we would follow with it. And so when we were considering the different types of measures we had, our overall outcome goal was to increase the use of IA and reduce emergency cesarean deliveries without increasing adverse maternal or neonatal outcomes. So in looking at the different components, we wanted to make sure that we were able to have process measures that would lead up to that outcome. And so we identified the need to increase the number of eligible patients with IA ordered at admission. And in order to get there, we needed to look at how you would develop admission strategies in order to have both policies in place, but the necessary steps so that the admission process and then follow through in labor would be possible following intermittent auscultation as the strategy. So taking all that together, we looked at what do we need to do to prepare sites for success in this area. And initially what we focused on was you need to have policies in place at the unit level that are evidence-based and that everyone understands and appreciates. So there's a number of resources from professional organizations to inform those policies. And I note the key ones here that look at the fact that you have fetal heart rate monitoring principles and practices. This has been updated recently and includes a much bigger section now on intermittent auscultation. The American College of Nurse Midwives has a clinical bulletin that goes through great detail, highlighting the elements of care that are involved, the standard utilization, the timing, et cetera, and also includes detailed description on the how-to. The ACOG practice bulletin gives guiding principles. It doesn't go into as much detail about the how-to. I think you gain more of that from the ACNM and AWAN documents, but taken together, it supports the physician practice basis for guidelines to be included in consideration here as well, so that it's not just a nursing strategy, but that you have inclusivity of all the different provider groups represented. And then you also need to look at the standards for professional registered nurse staffing for the units. This is a space where most of the questions come up about people not wanting to do intermittent auscultation, is they immediately just say it takes too much time to staff for that. And in this context, what I highlight is that when you look at safe staffing recommendations, they really focus on the need for the staffing level to be one-to-one in active labor, regardless of whether you're doing intermittent auscultation or continuous electronic fetal monitoring. So if you're meeting the true safe standards for practice staffing, then you really need to be thinking about meeting that regardless of the mode of fetal assessment. And I know that's easy to say, and we can talk about that some more, but that really is where the focus has gone in a lot of spaces. And AWHONN would say, if you're really doing optimal nursing staffing, then you shouldn't have a concern about not being able to meet the standard for fetal assessment using intermittent auscultation as well. And in addition, in terms of the how-tos to perform intermittent auscultation, this is just an example of one of the monographs that's included in the auscultation. This is from the old manual, but it's repeated in the new. You also had a prior webinar that went through really good detail on the process of doing intermittent auscultation. So I would encourage you to also refer to that as well. And then, as I noted, the AWHONN and ACNM documents. And then we're going to talk about a few more recent resources that are available that we found to be very helpful for our sites. And in particular was IA training that was looking at simulation-based auditory review of what you were hearing, which is a different skill than seeing. And so the Perinatal Quality Improvement Organization, initially with Amy Romano, developed a intermittent auscultation education training program. And we were able to make that available to all of our sites for a train the trainer model, where you can go through the training and you're listening to what you would be hearing if you were auscultating the heart rate tracing, and responding and interpreting what you're understanding that to mean. AWHONN has since adopted this simulation training and done some small revisions to it, and it's now available through the AWHONN website as well. What I really liked about this opportunity is that it acknowledged that it's a skill set to listen to the heart rate and be able to interpret it appropriately and respond. And so when you look at what's a part of this resource material, what you see is that it looks at why listen when you can look. It looks at performing and interpreting intermittent auscultation, and then it does the simulation and practice skills. Similar to all the time you think that we spend doing continuous electronic fetal monitoring interpretation training. We often, as part of being a brand new nurse on a unit, have a series of educational sessions that look at how we develop the skill set. But we sometimes treat intermittent auscultation as if it's not a unique skill set, that it's something that you just do. And that's really a limitation on, or I would even argue, puts you at risk when you're doing intermittent auscultation if you haven't had appropriate training and an opportunity to develop the skill set that's necessary for the use of intermittent auscultation. And so the use of a simulation training, whether it's done through one of these mechanisms or you have other ways that you can do that in your sites, we found to be very valuable in our work. The other thing that comes up when you're thinking about policies and procedures is there is variation in what you see in the professional guidance about how the frequency of intermittent auscultation should occur. What you see is that ACOG actually recommends 30 minutes in active labor and Q 15 minutes in second stage. ACNM and AWHONN actually have a more narrow window of time for performing intermittent auscultations. They argue for a 15 to 30 minute in active labor, and actually define that to 5 minutes in second stage. Now, A1 and ACNM have worked together to try to align their timelines and to use the same evidence base. And overall, in the new ACNM guidelines that are in process, they will align with A1, but it does create some challenges. And this is where some of the staffing questions come in. When you see something that says 5 to 15, the question is, we're used to seeing one measure. We're used to seeing 5 minutes or 15, not a range. And in this context, the reason for the range is to align with the labor pattern and process, and best practices for doing the intermittent auscultation is actually between contractions. And so in some situations, you may need to use a different interval within that range in order to accurately assess the fetal heart rate tracing between contractions. And so the take-home message here is that the range is been used over time. There isn't a really clean randomized controlled clinical trial looking at whether it's better to do 5, 15, 20, or 10. There's some work that's being done in European countries now as a collaborative trial to try to better understand what this is. But the guidance that we have from the studies to date put us in this range. And so with the staffing being appropriate, the goal would be being able to achieve these interval ranges as much as possible. The other thing that I would, was a really important component of preparing sites to be effective in their use of intermittent auscultation was to develop standardized order sets. And at many of our sites, they used a hard stop approach where the initial order that was written was done so with the goal of being able to have you think to stop and ask the question, is this person eligible or not for intermittent auscultation? And using the hard stop approach was a really effective way in almost all of the sites to be able to really have all providers get on board with the initiation or launch of the project. Not using a hard stop created some challenges as people were adopting new practices and making a practice change. So if you have the opportunity to use a standardized order set that does have a hard stop, that can be really effective. The other strategy that was used at a lot of sites was to have standardized notes in the EMR that outlined how you would look at and interpret the intermittent auscultation so that you had documentation that mirrored and made it just as easy as if you were doing continuous electronic fetal monitoring, so that there's parity in how you're documenting whatever assessment strategy you're using. The other thing that was put together as far as resources to prepare sites to launch their initiative was to have Doppler kits and sort of cheat sheets that gave them examples for documentation so that at the ready, this practice change was easily adopted and something that they didn't have to stress or to feel like they had to recall spontaneously how best to implement the change. And the Dopplers, people often will cite the need to get the Dopplers as an expense, but there may be strategies where you can, like your prior webinar suggested, looking in the clinics for all the unused Dopplers that might be available, so that it may not always be a high cost, but that's one strategy. The only thing I would caution you about is that some people will use the fetal monitor as the source of their Doppler in order to get the fetal heart rate assessed intermittently. The challenge there is that sometimes then you start to do a continuous tracing, and you just have to be careful that what you're doing is still intermittent auscultation, listening and interpreting what you're hearing in that interval, instead of trying to look at small strips that you're then interpreting, because then you have to revert back to what do you really need for a quality fetal monitoring strip and interpret that, because otherwise you're sort of in a a middle ground where you're overusing the auscultation strategy and you're underusing the outcome of it, which is the fetal monitoring strip. And so that's something to be cautioned about. And that's why Dopplers tend to be a better strategy. They really hold you to the listening, interpretation, and moving forward, where some people will make decisions about use of the continuous monitoring for 5 minutes, 10 minutes, et cetera, and making interpretation there. And there really isn't a good evidence base for that as a process. And then finally, the last sort of strategy piece that you need to have in place at the unit level is some patient education resources and materials to be able to provide to consumers so that they can make good decisions about what type of monitoring works best for them. We often have great ideas on the hospital side. The other example I give is when we discourage early admission in labor, but sometimes we forget to tell the people who are going to be on the receiving end of that care about that strategy. And so making sure you have good communication in place about what's available and the whys behind it that you can roll out to patients and families. And then once you have all of those materials available, the policy, the training and education for all staff, and patient education resources and materials, you want to combine that in terms of readiness with different reports that you can track the metrics and measures that are available. In the obstetrics initiative, we have a ongoing dashboard that's available for all of the clinically abstracted data. And so we added in different metrics about the indication for whether or not the person was monitored by intermittent or continuous EFM, and if by continuous EFM, the indication. And whether we also look not just at admission, but during active labor, so that we could look at what we call the conversion rate from admission intermittent auscultation to continuous during labor or not, to get a sense of how much the intervention was being able to be maintained throughout care. And then sites could compare their monitoring rate to other sites in the collaborative, as well as look at their own hospital rates, so that they had a way to track the implementation, the rate of ordering that was in alignment with the guidelines, and then what was happening during active labor as well. And we also provided sites with a template that they could use for PDSA cycles, so that they had a way to document the different steps and how they were implementing them and what was working. And we struggled with what the outcome measure would be that we would incentivize for our work. And what we really ended up focusing on was measuring the ordering of intermittent auscultation. And it seems like that's a reasonable strategy, but the problem with that is that ordering isn't necessarily the behavior of doing. And so that was why we had the sort of balance measure of looking at what was happening in active labor. And so one of the things that we saw that was a challenge is that some sites were very good at building in what they called dual orders, where they said intermittent auscultation or continuous electronic fetal monitoring based on indication. So they had 100% compliance with ordering intermittent auscultation, but they didn't necessarily implement it. And so when you look at the outcome of our project, then we ran into some different challenges. And so in addition to looking at those outcome metrics, we also then looked at the story behind the project. And this is where we were able to uncover some of the challenges with the final impact of the work, where the ordering didn't necessarily react or correlate with the behavior of actually doing the intermittent auscultation. So that's a lot of words about steps and implementation. And so I want to just talk a little bit then about what we saw as opportunities and where we had some need to adjust. And this is why I call it smoke and mirrors, because this is where we ran into some of the bumps. You know, whenever you're following working in this space, you're always following the same standardized steps of any QI initiative. You know, you want your team to be well engaged and supportive. You've got to assess the readiness, allow for the education and training that I've talked about. We really advocate a clear launch point on the unit and then following your metrics and measures. This isn't new information to you and probably the ways you've been doing a lot of the work. But what's interesting about intermittent auscultation is it takes on a little bit of a life of its own. And there's some work out there that looks at facilitators and barriers to using intermittent auscultation. And I won't go through all of these pieces, but I will refer you to this paper. And full disclosure, I am one of the authors on it, so I'm not overselling it, but I think it lets you think about some of the sort of strategies you might need to use to bring a full team together. Because one of the things that we saw is that we had a lot of hospitals where there was high nursing engagement in the use of IA, but not necessarily provider support for it, and sometimes vice versa. And so thinking about how you're coming together as a team is really important. And that's what a lot of these points address. And it includes recommendations for how to address what are some of those challenges. There's another resource out there that looks at QI implementation to strengthen IA practice that goes through an 18-month CQI program across birth centers. And it really makes the argument for how you have to do the iterative strategies. And it's from this work that those simulation trainings were developed. And so this is another resource that might be helpful to you. But in terms of overall lessons learned, it really is a significant paradigm shift to be using IA. And because we are so used to seeing information around fetal assessment instead of listening to it, it asks for a whole new skill set. And many providers, it's not that they're against the value of intermittent auscultation, it's that they have to learn new skills to know that things are okay. We have gotten so accustomed to being distant from where our patients are and being able to look at information coming from a monitor wherever we are, that's very different than having to speak to someone and say, how are things going? What is the fetal assessment? What is the outcome of the intermittent auscultation? So it's asking people to work differently and to communicate differently. So thinking about it as a paradigm shift and acknowledging that is an important piece. People often think that IA is just a simple thing to do, and they don't do as much training and focus on preparation. But it is a new skill. It's something that does require training and support as people are learning it. And policy development is really critical. And then you actually have to follow the policy. As I said, sometimes we convert to using electronic fetal monitors as our Doppler, and then we're tracing. We're not actually listening to the intermittent component. So those are things that are really hard to sort of make sure that you stay on task with. The unit culture has a lot to do with it, and being honest about where people are. If you really have strong divergence between the providers about the value of intermittent auscultation, there may be a different project to start with to try to build that coherence and collaboration around a project first to build trust before you select intermittent auscultation. And in making sure that you involve all the different parties. And as we saw, the ordering is not the same as the doing. And so having documentation as the sole metric put us at risk for people getting big compliance rates, but not having the impact that we hoped they would have. And then making sure to make space for the pain points. People will pick the evidence that is most resonating with them. That's why you will hear people say, oh, use of intermittent auscultation is related to high seizure rates. Well, that's not actually what the literature tells us, but that's how sometimes people will stand with their evidence based on their perspective or understanding or prior training. Making sure that you think about how you compromise, but making sure that you're following evidence in making your policies. Sometimes we create policies that have such long lists of people who are excluded from intermittent auscultation that we dilute the impact of it even being something that could change our NTSB C-section rates. Being sure that you're focused on patient desires and interests, that you're supporting nurses to have comfort with these new skills, and that you also acknowledge oftentimes, because it's a new way of understanding what's going on with fetal assessment, providers may often ask, well, how do I know the nurse is doing the right thing? Or how do I know that they're hearing the right thing? And that can be taken as a very offensive kind of comment. Like, what do you mean you don't trust my skills? But it's coming from a place of insecurity about, this is a new way of me understanding what's going on, and I've got to learn that new skill too as a provider. And it's also important to recognize that intermittent auscultation does stay under the microscope because it's different. And so if there's ever unexpected outcomes, intermittent auscultation is usually the first thing that's pointed to. And so being comfortable talking about anxieties and fears about impact on outcomes, so that people can rest into collegial conversation and support and acknowledge those fears, but then rest back into the evidence that would argue for still moving ahead with the intervention. So this is just an example of how we've looked at compliance across, and to give you sort of a summary of where we were and where we came to with our work. What we found is that the implementation of our IA bundle alone has not been shown to make a significant difference in our NTSB C-section rates at the implementing sites, either just looking at compliance rate or at the site level. And we think this is primarily because of the ordering as the primary metric. But when we look at all NTSB admissions for planned labor, having IA ordered at admission compared to continuous was associated with a significant decrease in the risk of having a C-section. So the reason I have this, let's not throw out the baby with the bathwater. If you just look at the IA implementation bundle, the initial response was, well, it's maybe that's not of value. But I think it was our metric that was the challenge when we look at the secondary understanding of IA still being associated with the lower NTSB C-section rates. So still opportunity. I know this is not easy to do, and that it takes a lot of dancing is how I refer to it on the unit level, but it is something that I think really can make a difference and is also responsive to patient care needs. So I'm going to stop there and open things up to either questions or next steps.
Thank you so much. Anyone with any questions, please feel free to raise your hand or pop them in the chat. Amber's also manning the chat, so feel free to ask your questions.
Hey, Dr. Lowe, thank you so much for participating. I don't know, as a provider, I learned a lot. I'm always learning a lot as we go. And I think one of the observations I have is that as providers, we're really used to doing Dopp tones in the clinic setting, right? During prenatal visits, we Doppler patients. And so I think sometimes some of the disagreements between provider and nurse skill level can come from just the daily experience that many providers have auscultating fetal heart tones. And so I do like that you're pointing out that this is a skill that should be attained. And not all nurses, have this in their workplaces or even come to your hospital with this skill. And so I think having opportunities for training are really important. My question for you is, you mentioned it briefly that exclusion criteria can really play a part in the implementation of an IA bundle. And what I've found is that exclusion criteria can vary by facility. And I think a lot of the criteria that we use for exclusion is sort of intuitive to us, like, if the patient is high risk in any way, then we probably should be monitoring the fetus more. But I'm wondering, is there data to support which exclusion criteria we should or shouldn't be using for intermittent auscultation, or are we sort of doing this presumptively?
There is data that's been part of the different studies that have looked at intermittent compared to continuous that have sort of been collated to give you a general list. And I will say we went back and forth and for fear of, I always hate to do this because I don't want to make everybody get dizzy. But I think that we had our metric that we used, which is right here. These were the ones that we felt or we landed on as evidence-based guidelines. Now, we did go back and forth because part of what's happens, and even in the paper that I cited at the very beginning that was just published yesterday, they often will list at the bottom medical comorbidities. And then that becomes the sort of everything bucket. So we've tried to stay with this particular list and been very tight with it, because we have a lot of people who try to, who would say the person's not eligible, but they don't meet any of these criteria. So there is evidence underneath this list, and I can share with you what's been put out through ACNM and in the more recent reviews, but this is the general sort of bucket. I will say that when we first put this list together, we thought about all the medical indications, and we did not include patient preference. And I had a lot of anxiety about putting this on here, because sometimes patient preference isn't their preference, it's the provider preference. And we were fearful that that would really derail the process as well. And that didn't seem to happen as much. But by narrowing the list, we did have people sort of stay in line with that. And then we also offered updates on what people felt at their site were the primary reasons that providers were most anxious about not performing continuous, and tried to then bring evidence to what they were concerned about as a strategy. Did you have particular things that you see coming up a lot, or just the wide variation in policy?
No, that response was really helpful, and not really particular ones, just the creep, right?
Yeah.
The creep
Yeah.
that comes at just sort of provider level discomfort. And that really comes from, I think, tends to be subjective historic
Right.
experiences versus any objective criteria.
Yep, absolutely. And it's that whole paradigm shift of, if we think about the routines we follow in triage every day, we go in and we immediately go right to the fetal assessment, is the general routine. And so all of a sudden you stop a person to say, well, that's not where you look. We've already done that. The nurse has done that information and gathered it. So it's asking us to rethink how we start our routines. And that's where I think the creep comes in. It's like, well, wait a minute, I need this, even though I have no evidence to support the why.
Thank you so much. We also had another question in the chat from Christina asking, have there been any lawsuits with IA without proof of an electronic fetal strip of FHT versus an audible FHT IA?
So that comes up pretty consistently as one of the big anxieties, and is that it's that the increase in, what I'll say is that IA is perceived as the liability, and continuous is perceived as the safety net. And in actuality, what we saw in our work, and I'm happy to provide another paper that we did about this, but what we saw is that actually having the continuous electronic fetal monitoring tracing presented more risk of interpretation. And the fact that there's a lack of standardized interpretation, there's been a couple different studies that have been done where people are all looking at the same tracing and they come up with different interpretations. So that actually is where more of the medical liability rests. The challenge is that if there's an unexpected outcome and everybody's followed policy, there still is the anxiety that IA is potentially seen as being different than standard practice. And so that's where we hear a lot of providers have concerns, as well as nurses. And the way that we've tried to support their resting into the evidence is by reviewing the evidence and supporting the policies. We don't have a case that's been demonstrated to show that when you follow the policies that are in place using intermittent auscultation, that you have increased risk. The only space for increased risk, and this is consistent also with continuous electronic fetal monitoring, is when you're not following the policies that are in place. So that does mean adhering to best practices for how you do intermittent auscultation, and then maintaining the frequency with which you say your policy, your policy dictates to do the intermittent auscultation. So that's sort of a lot of words of saying, as long as you do it right, you're in that safety range as you would the same thing as if you're doing continuous and you're following the evidence and reviewing it appropriately.
Thank you so much. I might grab that study from you later just so that we can have it attached to the email as well. But thank you so much. We're almost at time here. I am just going to advertise super quickly the next SOAR webinar in October. We're having Dr. Stephen Clark talk about Category 2 EFM. So we would love to see you all there. Thank you so much, Dr. Lisa Lowe. We appreciate you coming in, taking time out of your day to talk to us about these really important topics.
Thank you.
Thank you, everyone. Great. Thank you so much again, Dr. Lowe. I'm going to stop the recording.